Thank you, Corey. Not Starbucks. Anyway, look, I'd like to welcome everyone today to what we as the Alliance believe will be a very important and very, hopefully, collaborative meeting. And the most important thing that we know about this is that we hope this to be the most successful National Critical Issues Forum that we've had, albeit in a virtual environment. As stated earlier, value in the National Critical Issues Forum is generated in our conversations. And we ask each of you that you participate as we want to hear from you. We will also hear from our respected speakers who have impressive resumes and have themselves pioneered innovative developments that have led their programs to success in increasing the number of organs transplanted. But remember, for us, the key to success in this is dialogue. The objective is for us today to work together to create solutions. And what we have to address is the problem that we are all faced with, and more importantly, the problem that is impacting all of our patients, which is the supply-demand mismatch. We must learn how we can adjust to the current state of play, and we have done a very good job despite the COVID pandemic, with transplant numbers paralleling, if not slightly exceeding, the previous years. But in this time of change, we must remember one thing, and to quote Stephen Haynes, change is about the only predictable factor in our future. And the focus of this meeting today is how we address and adapt to changes and look for the positive impacts. The National Critical Issues Forum today will illustrate to us how we overcome these changes, and in some instances, how we might capitalize upon these changes. And we have intentionally limited the number of attendees so that we have a more intimate environment, and equally so that we see a more valued experience for everyone who participates. So please remember to engage in the Ask Me function during presentations if you have questions, so that they may be directed to the person giving the presentation. And similarly, as we move forward, anytime the conference is running, and any time at all actually over the next 48 hours, we're going to have the opportunity to enter general discussions. And there we would like you to develop dialogue with other members, much like you would at a normal meeting where you would meet people outside and discuss new ideas generated from the talks. Finally, during this afternoon's Success Lab sessions, please go on your Zoom camera. Seeing you and seeing others allows us again to participate. So in moving forward, the most important thing I'd like to do is remember that we have sponsors. And CareDx is a leader in precision medicine solutions and focuses upon discovery, development, and commercializing certain and important clinically differentiated actions that basically provide high-value healthcare solutions for transplant patients and their caregiver. It's a company that is both committed to transplant, and it is terribly committed to the patients that we serve. And thereby, they have been able to, with their innovative and intelligent solutions, provide greater opportunities. So for this, I would like to thank CareDx, and you can look them up on caredx.com for more information. Now, in moving forward, I'd like to give an overview of the first session, which is dedicated to setting the stage for the broader conference. Now, here, basically, there are steps when people are seeking to realize opportunities and to adapt to change. And moving forward here, what we see is that we have to encourage all attendees to go through a series of steps. Now, in doing this, we have, and I'm just moving through my slides here. Can I get the next slide, please? So what we have here is, when we're utilizing data, we're going to have discussions that are going to come forward with Jon and Andrew Way, two critical elements in the SRTR and also the Hennepin Research Institute. And they will be discussing where you find the data as part of your steps. The first steps that people really want to know is, and I think we need to think forward, and that's why we're talking here about destination thinking, is where do you want to be? However, to get to where you want to be, you need to know where you are now, how you might get there, and then how you may identify that you are there when you actually reach that point. Next slide, please. So in destination thinking, next slide, please. So I'd like to bring up, actually, this is probably something I should have presented earlier. I have no relevant disclosures to this meeting, but I would like to point out, albeit that I talk on occasion to Novartis and for Gilead as an educator on the advisory boards, what I do understand is that my participation in this meeting has improved my program. I have learned from those individuals who you'll be hearing from later, and I'll illustrate to you how those changes have demonstrated results. So in moving to this, remember that knowledge creates a meeting. Next slide, please. Tommy Thompson said in 2001, we need not only transplant experts, but also passionate advocates and new ideas if we're going to increase organ donation. And between 1999 and 2008, organ donation changed. Next point, please. And what we see here in terms of transplant numbers, that we went from 5,000 in 2000 to just over 6,000 transplants in 2009. I'd like to draw people's attention, however, to 2001. And although we saw an increase in transplants and a large percentage of that increase related to the rise in living donor, in the subsequent year, we saw an increase in deceased donor and a dramatic drop in living donor. And that's a function of this environment. Next slide, please. That environmental change that we saw in 2001 was a donor death in New York City. However, we saw with the Transplant Collaborative a significant increase in the total number of transplants. What we have seen more recently is a heroin pandemic. And next touch, please. And with the heroin pandemic, we saw a dramatic increase in the total number of deceased donors, and importantly and concurrently, an increase in living donation, as the public has further adopted the opportunities associated with this in liver transplantation. Next slide, please. And why was this important to us at Intermountain? It's because I think we were a near first with one program in Boston doing this, and then us developing this program. And next slide, please. And what this did to us is it changed our total number of transplants. So there is a key concept here that we must remember, and what we have identified, and what our program at Intermountain has identified. We need to know where we are, we need to know where we want to be, and we need to know what we need to acquire both internally and externally to achieve this. We have one mission, and that is to save more lives. So on that note, and in moving forward, I'd like to introduce Jon Snyder. He is here to assist us in identifying some very important points, which is where we are and where we need to be. And he will also provide information on what impacts our decision process. He is the Director of Epidemiology, and he'll be detailing what he actually is in his slide. But I will say, from my perspective, he is an incredibly accomplished individual who has made incredible contributions to the field of transplantation. And I would say that he and his initiatives and those of SRTR have been instrumental in the development of our programs. So on that note, I'd like to have Jon speak to us now by video, and we will move forward to his discussions. And then afterwards, Andrew Way will be participating in the Q&A, also another instrumental individual of those two institutions. Thank you.
Good morning and welcome to the National Critical Issues Forum. My name is Jon Snyder. I'm the Director of the Scientific Registry of Transplant Recipients, and I'm the Director of Transplant Epidemiology at the Chronic Disease Research Group at Hennepin Healthcare Research Institute in Minneapolis, Minnesota, and proud member of the Alliance's Board of Directors, and just happy to be here with you this morning virtually at the National Critical Issues Forum. I've had the opportunity to work with Dr. Gilroy leading up to my presentation, and I apologize that I cannot be with you live this morning. But I know that Dr. Gilroy has some great information to share, and I appreciate all of his insights and information working with me as we've prepared this talk. So I'm going to talk about utilizing data to improve your organization's performance. And I often get this question when I'm visiting various transplant programs as well. How would you think about our performance relative to our peers? And I just wanted to sort of take you on a journey through that process, what I think about using data that we currently have available. So we're going to walk on through how my mind works. As a way of disclosure, I do obviously serve as the director of the Scientific Registry of Transplant Recipients, but these views are my own and do not necessarily reflect those of the U.S. Department of Health and Human Services. So make that known. Perhaps some of you have seen me speak before, and I've developed this over the years, thinking, taking off of Maslow's hierarchy of needs. I've sort of morphed it and stolen it into my hierarchy of data needs. And I think this is an informative structure for how I think about data. Starting at the bottom of the pyramid in our basic needs, we have information out there that we know exists. We need to actually try to use that to reach our goals at the top of the pyramid. But what is the process from going from information to goals? And in the basic needs category, I've put, well, first we have to transform information into data points. If we can write down and capture those ideas in the form of data, then we're one step closer to reaching our goals with that data. But first, we have to transform the data into metrics. And so when I think of metrics, I think of it's a number that's calculated off of data, right? So we're taking the data and summarizing that somehow into a metric that might give us some insights, right? So, but that's a distinct step in the psychological or intellectual path here, is moving from metrics to insights. How do we actually think about those metrics, and what are we trying to learn from them? What do they mean? If we can understand that and gain some insights, then we move into the self-fulfillment zone of the pyramid, where we can actually take action, right? We understand what the metrics are telling us. We can think about them in the right way. We understand how they're calculated, what they mean. We can perhaps take action to improve things within our system, within our particular transplant program. And obviously, all of that, if we're successful, will lead toward achieving some goal. And obviously, one of our goals is to have the best outcomes for the patients that our transplant program is serving. And so I think that as how I think about moving from information all the way up to the top of that pyramid, that we can actually use the information to achieve some goals. So I'll walk you through some of the available data that the SRTR makes available. Obviously, the SRTR is not the only source of information for data for your program. And I often tell programs, look, I know that your program has more specific data regarding the patients and donors that you serve. And so I don't want people to think that the SRTR data has to be the end all be all. Of course, you have data within your organization that you can look at, and I encourage you to do so. But I'm going to pick and choose from some of these as I flow through the process here of thinking about waiting list outcomes. Look at some waitlist mortality data, transplant rate data, and overall mortality after listing data, which is a new metric that we have recently released into the public reports. We can consider OPO data from our OPO or other OPOs. We can think about how we handle offers. When we get organ offers, are we accepting those at a rate that is similar to our peers or different from our peers? I think we can gain some particular insights around offer acceptance, and I'm actually particularly excited about that data and what programs can learn from looking at data on offer handling. And then, of course, the ultimate goal is the outcomes for our patients, both overall mortality after listing, but also the transplant outcomes. What are the short-term outcomes? What are the midterm and longer-term outcomes? Of course, the SRTR currently is reporting 1 month, 1 year, and 3-year outcomes, and I'll let you categorize that, as you will, into whether that's short-term, midterm, or longer-term. We are working on a way to present 5-year outcomes as well in the reports, and so that is a teaser of things to come. So as a way to walk through the examples of how I would think about this, Dr. Gilroy has given me permission to use his liver program at Intermountain Medical Center on the left as an example, as a case example. And so I thank Dr. Gilroy for that. I think it's often intimidating, I guess, to use your own program's data in a public presentation, but I appreciate his willingness to do so. In fact, he suggested it to compare his program data to a program with a liver program that seems to have exemplary outcomes and statistics associated with their program, and that's the Mayo Clinic liver program in Phoenix, Arizona. And so for most of my presentation, I'm just going to compare and contrast, and you can glean insights from what I say. Think about your own way of how you would think about this, but I'm going to walk through a comparison of these two particular programs. So if you want to do this on your own, I will point you to our website, and I just want to make a few points. This is at srtr.org, and I have searched at the top there for a liver program, and I'm just showing you a screenshot of what you will see. And I want to point out the new interactive report that's available for all transplant programs. We have attempted to take the 50-odd page PDF report that we have traditionally created for programs and converted that into a modern, I think it's beautiful. I'm biased, of course, but I think it's nice to work with a nice modern interactive data visualization for your program. So much of what I will show you today is from that new interactive report. If you haven't seen it for your program, I would encourage you to go there and check that out. So, okay, some brief data here just to begin, looking at Intermountain Medical Center's liver transplant program. One of the first things you would see when you bring up that interactive report is an overview of the wait list. And I won't go through every number on this plot, but just to show that this program for this 1 year period of time had 67 people on the wait list at the start of the year. They added 73 patients and subtracted 69 patients from their list. And then the reasons for those subtractions are below in the reasons for removal, 50 of which received a deceased donor transplant and 3 received a living donor transplant. And then that resulted in 71 patients left on their list at the end of the year. And that's just a broad overview of the list. And then the website goes on to detail a lot of information about the wait list, about offer acceptance, transplant procedures, and transplant outcomes. And I will show you some data from all of those locations. But first, let's look at Intermountain Medical Center's transplant rates. And so this would appear toward the bottom of that first page when you go to the program. And this shows you 4 different graphs. In the top are just comparing the adult and pediatric and overall observed and expected transplant counts. You can see that the dark blue bars on the top left are higher than the light blue bars. And so that would indicate they're transplanting more patients than we would predict that they are transplanting. In the bottom left, we have what we call the transplant rate ratio. And that blue dot from that rate ratio is displayed in the bottom right, comparing that blue dot to all other programs. And so you can quickly see where your program stands relative to your peers. When we interpret that transplant rate ratio, in this case, it's 1.27. Higher than 1 would indicate that they're transplanting at a rate higher than the models would expect. And of course, these models are risk adjusted, and you can find those risk adjustment factors on our website. So we're trying to compare apples to apples across transplant programs. A 1.27 transplant rate would indicate that they are transplanting at a rate that's 27% higher than the models would predict. Okay, so something below 1, say for example 0.75, that would indicate that they are transplanting at a rate 25% lower than expected. And so in this case, they are transplanting at a rate higher than the models would predict for the types of patients on their list. So what can we learn from that? This is just zooming in on it again. The transplant rate ratio here with its credible interval is shown, 1.27, which is significantly higher than 1, given that credible interval. And again, on the orange plot here on the website, you can hover around on the orange dots and you can see exactly which program is each of the dot. It will tell you which dot is which program. So if you wanted to pursue communicating with your peers and asking them questions. How do you achieve such a high transplant rate? We hope that the new website makes that much easier to do so, because you can hover over any one point and learn who that program is. So let's compare that to Mayo Clinic. So in the top left here under Intermountain Medical Center is just the data I've just shown you. And then to the bottom right of this slide across the diagonal, we have the Mayo Clinic in Phoenix, Arizona. And you can see they happen to be the highest transplant rate in the country, which is why I've chosen them as a comparator to Dr. Gilroy's program. So their transplant rate ratio, you can see in the bottom right, is at 3.25. So they are transplanting at a rate 3.25 times what the models would expect, which is indeed the highest transplant rate in the country. And so you can compare, they're about the same size, if you will, of Intermountain Medical Center in terms of person years. The dots on those plots are stratified left to right by the size of their wait list, as measured by person years of time on the wait list. And so you can see that the Mayo program in Arizona is approximately the same size as Dr. Gilroy's program at Intermountain Medical Center, but is indeed transplanting at approximately more than double the rate of Dr. Gilroy's program. And that's not to say Dr. Gilroy's program is, of course, a bad program. They have a high transplant rate as well, but just by way of comparison to what's being achieved at Mayo. And so how do we start to move? We looked at some metrics. How do we move from metrics up the mountain here to insights? So I asked the question of myself, well, why is it that the Mayo program in Arizona, which is the UNOS code AZMC, why do they have a higher transplant rate than Intermountain Medical Center, which is code UTLD? What can we learn? And so I started to just poke around in the data a bit, see what insights I could glean. And the first question I asked is, well, having a high transplant rate is a function of keeping my patients alive on my list until they are able to get offers. And it's also a function of then accepting those offers at a reasonable rate once I'm starting to get them for my patient. And so the first question I asked is, well, let's look at the risk of dying before receiving the transplant at the two programs. And I asked the question, do candidates at Mayo, Arizona have lower risk of dying before transplant? And the answer is no, they don't. Actually, UTLD's program on the right has a lower mortality rate ratio estimate at 0.65 than the Mayo program, which is about exactly at the national expectation of 1 at 0.97. And so it's not actually true that it's a difference in Mayo's ability to keep their liver patients alive in time, long enough to receive those offers. So both programs have lower than expected risk of dying on their transplant rate, but indeed the Dr. Gilroy's program has an even lower risk of dying, their patients dying before receiving their transplant. So that's not the answer. How about offer acceptance? Is Mayo, Arizona more likely to accept organ offers? And the answer here is yes. You can see we present on the website what we call organ offer acceptance ratios. And this is a similar concept to the transplant rate ratios, but it's asking the question, is your program accepting offers at a higher or lower rate than our models would predict based on what other programs are accepting for similar candidates with similar donor offers? So there's a lot of factors that go into these models that predict offer acceptance. And so those are also available on our website. I encourage you to go look and see what we're able to adjust for when we're making these determinations. But essentially we're saying for similar offers to similar candidates, trying to compare apples to apples, how does UTLD, Intermountain, compare to Mayo, Arizona? And so let's look at the results here. So each of these left and right plots here, on the left, we've got Intermountain Medical Center, and we can see that their offer acceptance ratio is 1.64. So indeed, they have a higher than expected offer acceptance rate overall, 64% higher acceptance than we predict. And you can see how that compares to the national distribution, right? So the box plot to the left that's labeled national shows the spread of offer acceptance across all liver programs in the country. And so this helps put UTLD's offer acceptance practice in context of all programs in the country. If we look to the right, we see Mayo, Arizona, And here we have an offer acceptance ratio of 4.02. So they are actually accepting offers at a rate 4 times the national expectation for the types of offers and types of candidates. And again, here, just like their transplant rate, this is the highest in the country. Okay, so they are very likely to accept offers for the livers that they are receiving for their patients. So this might be one explanation for that higher transplant rate, is they are more likely to accept offers once they receive them. Now, the obvious question is, well, let's look, what types of offers are these? Well, our website presents a number of subcategories for these, which I'll show you in a moment. But here's the overall data for Intermountain versus Mayo. If you look on the left, these data are also available on the website. They received at Intermountain 633 offers. They accepted 50 of those, and expectation was they would accept approximately 30, right, 29.6. And so that's how we derived that their offer acceptance was 64% higher than we expected. Comparing that to Mayo, of the 1,378 offers received, they accepted 148 of them, and we only expected them to accept 35. And so quite higher than we'd expect. That results in the offer acceptance ratio of 4.02. But when we look at subcategories, we present on the website a number of what we consider to be more challenging types of offers to accept. And so I asked the question, is Arizona more likely to accept higher risk organ offers? And again, the answer is yes. And we present here 5 different subtypes of offers and what their offer acceptance was relative to what we expected. And so looking from left to right, comparing Utah to Arizona, were they more likely to accept PHS increased risk? Yes, right? We have a 1.37 offer acceptance for Intermountain versus 3.3 for Mayo. You can see in the DCD column, for DCD offers, Mayo accepted them at a rate almost 11 times expectation. So they are very likely to accept DCD offers relative to their peers. They're twice as likely to accept HCV positive offers. And we get into some offers that have been perhaps turned down by other programs, might be deep in the offer list. If the donor was more than 500 miles away, Mayo is accepting those at a rate 7 times expectation. And indeed, if they're more than 50 declines ahead, these are actual declines. So Mayo was at least number 51 on the offer run. They are 12, almost 13 times as likely to accept those. So you can see across the gamut of offers, it's not that they're just accepting the quote unquote good organ offers, they're accepting at a higher rate across the spectrum of offers. Does Arizona import more livers? And again, the answer is yes. Mayo, Arizona had, over the time period in 2019, 66% of their liver transplants were imports, versus at Intermountain, it was 42%. So yes, they are also taking more livers from farther away, what we would consider outside of their donor service area. So for receiving more organs that we don't call quote unquote local organs. So does Arizona's higher offer acceptance lead to worse patient outcomes at 1 year? And I've heard this speculation before that if I accept offers at a higher rate, I am going to risk my program's outcomes because I'm accepting more higher risk organs. And so is it true that Mayo is having systematically worse patient outcomes at 1 year? And the answer is, again, no. And if you compare, these are their first year hazard ratios for graft failure. So this would be loss of the liver graft or patient death within the first year. And you can see Intermountain on the left, their hazard ratio is just slightly higher than national expectation for first year failure at 1.09. But Mayo has actually better outcomes than expected, 0.63 hazard ratio, indicating a 37% better than expected outcome at 1 year relative to their peers for the types of transplants they're performing. And so it's not true in this case that Arizona is systematically, quote unquote, endangering their program's outcomes by transplanting these higher risk organ offers. Well, how about at 3 years? You know, I've also heard speculation that, well, you just wouldn't see it within the first year, but they're going to have worse outcomes at 3 years. And again, I think the answer from the data we're seeing is no. Intermountain's 3-year failure rate, 0.87, compared to Arizona's 0.93. So even at 3 years, both programs are still having better than expected outcomes relative to their peers. And so again, it's not yielding worse performance evaluations at 1 or 3 years. And now you might say to me, okay, John, that's fine, but that's one example. Are programs in general putting their patients or their programs at risk of bad outcomes with higher offer acceptance? And so this scatter plot here is something that we've been developing, and this concept of looking at, does higher offer acceptance across the country systematically, is that systematically associated with worse outcomes? And so here you can see on this scatter plot, the offer acceptance ratio on the x-axis. And so programs to the right of 1 here have higher than expected offer acceptance. And you can see the Mayo, the farthest right program is Mayo at the offer acceptance rate of 4. And then you can see to the left, those would be lower offer acceptance ratios. And then on the y-axis, on the vertical, we have their first year performance evaluation from the SRTR. And what you see here, you can see under the title there, R equals 0.03. That's the correlation coefficient between these evaluations. And so that's essentially saying that there is no correlation in our performance evaluations between having a higher offer acceptance practice at your program and systematically worse outcomes. There's no evidence of that. There's essentially zero correlation. And that is because our risk adjustment models take into account the fact that you're transplanting higher risk organs, right? So to the extent that we are able to capture that in the models, accepting higher risk organs for your patients are not systematically going to disadvantage your program for having worse outcomes at 1 year. Again, if we look at 3 years, same thing. In fact, the correlation actually becomes slightly negative here at negative 0.10, indicating a slight downward trend. So higher offer acceptance actually perhaps leading to better 3-year graft survival evaluations. So I think that's an interesting thing to consider, is that systematically accepting higher offers is not going to systematically result in worse performance evaluations. And I think importantly, when we look at overall survival following listing, I then asked the question, it's not just about post-transplant outcomes. If I have a higher offer acceptance practice resulting in a higher transplant rate with no association with worse post-transplant outcomes evaluations, I asked the question, is higher offer acceptance associated with better overall survival following listing? And here, in the case of Mayo, the answer is yes. And you can see that at Intermountain on the left, their overall mortality rate ratio following listing 0.92. That would indicate 8% better than what we'd expect for overall mortality of the patient following listing. This is the new metric in the SRTR reports. It's an intent to treat concept. So once you've listed your patient, what's their overall survival looking forward? So again, Intermountain is 8% better than expected. But looking at Mayo, they are 36% better than expected. So one of the takeaways I have here is that Mayo is keeping their patients alive at a reasonable rate on their wait list. They are accepting offers at an extremely high rate, the highest rate in the country, and that results in the highest transplant rate in the country as well. And they are having good outcomes following transplant, and that all adds up, right? This is the overall survival following listing is a composite of sorts of many different metrics together. And Mayo, Arizona has a 36% lower risk of dying following listing relative to what we would expect. And so again, good outcomes there as well. And so I think one of the takeaways here is that higher offer acceptance practices does associate with lower overall mortality following listing. And nationally, the correlation between higher liver offer acceptance and overall mortality following listing is negative 0.2. And what that says is that higher offer acceptance nationally is associated with lower overall mortality following listing. In other words, better overall survival for the patient. Does Mayo, Arizona have a better, quote unquote, OPO? Okay. Eligible death conversion is one of the metrics in our report, and I'll fully acknowledge the controversy around reporting of eligible deaths, that perhaps there's differences across OPOs in interpretation or reporting of the eligible death. But having said that, it looks like Donor Connect, which is the OPO serving the Utah area, and Donor Network of Arizona, both have about similar eligible death conversion. So I wouldn't say that there's a difference there across their two local OPOs serving their programs. How about liver yield? Of course, we have yield metrics in our reports for all of the organs, but I've just pulled out liver yield here. And Intermountain actually has a liver yield just 4% higher than expected at their OPO at Donor Connect on the left, a 1.04 liver yield ratio. That's saying that once we have a donor, they are 4% more likely than expected, so just slightly more likely to get those livers transplanted. And you can see in Arizona, it's actually closer to 1, so 1.01. So they're getting their livers transplanted at exactly the rate that we would expect given national experience. So I wouldn't say from these data that there's evidence that it's because that their local OPO is somehow, quote unquote, better. I don't see evidence of that in the data, at least. And so Dr. Gilroy said, well, what if we compared our program to other programs that are within 500 nautical miles of the Las Vegas, Nevada area, just as an example. And so I've sort of hypothesized here that I have a donor that is in a intensive care unit in the Las Vegas, Nevada area. And I just point out here the programs within 500 nautical miles of that donor would be, there are 16 adult programs. There's a few additional pediatric programs, but I'm just going to focus on the adult programs within that. And you can see where they are. We've got 3 in the Bay Area of San Francisco, 5 in Los Angeles, 2 in San Diego, 2 in Salt Lake City, and 4 in the Phoenix and Tucson area of Arizona. And so I just pulled some data from these, and you can do this too. All of the data I'm showing you is publicly available on the SRTR site. And I took those 16 programs within 500 nautical miles of that donor, and I looked at what's their offer acceptance rate, which is on the x-axis here, and what is the transplant rate ratio, right? So on both of these, I would say higher is perhaps better. And so you can see the correlation here. It's actually quite strong. And you can see I've labeled where Intermountain is on this plot, and I've labeled where Mayo of Arizona is on this plot. And I've drawn just a basic regression line through these points. Now, I'll be the first to admit as a statistician that the Arizona point is such an outlier here that it is weighing heavily on that regression line. But in general, I think the trend that moving toward offer acceptance rate ratios that are higher is associated with higher transplant rate ratios holds. And we showed that data earlier nationally. And so I think this is a way to think about and look at. And these data are easy to pull from our site, given the new way you can browse the data. And so I would encourage you to perhaps do something similar. So again, we see this trend that higher offer acceptance is associated with higher transplant rate. And I then pulled the overall mortality after listing. So again, now on the vertical axis, lower is better. We want lower mortality after listing. And so again, we have an association as we move across the zone of their offer acceptance practices, that we have this downward slope in these points here. And you can see where Intermountain sits relative to Mayo of Arizona. So again, and nationally, we showed the correlation between these things, right? So we know that this isn't just within this 500 nautical mile circle. This is a national phenomenon as well. So I think I've tried to take you on a journey of how I think we can use the data to easily compare our programs and perhaps gain some insights. And how would that then lead to action? How would that then lead to your program deciding, well, what's the goal and what could we do? Can we talk with Mayo, Arizona and say, how are you accepting this many DCD livers, and how can we learn from that, or are there other insights we can gain from talking to our peers? I didn't have time in this talk to touch on all of the tools we have available. Everything I've shown you previously is available on the public website today. But we do have a number of tools available on our secure site as well that your program can log into. We have QSUM charts, so statistical control charts for first-year graft survival, first-year patient survival, and offer acceptance. We have expected survival Excel workbooks that allow you to do your own subgroup analyses of your outcomes, both for first-year outcomes and pre-transplant outcomes. That would be like waitlist mortality rate or transplant rate. You can use resources on our secure site to do your own data quality checks, and we always encourage that. Better data allows us to do our job better. And there's a number of instructional tutorials and webinars available there, both there and on our YouTube channel. Would encourage you to check that out. And so with that, I will turn it virtually back over to Dr. Gilroy for discussion. And again, I apologize for not being able to be with you in person this morning. I appreciate your understanding, and I wish you all the best with the rest of the conference. Thank you very much.
And thank you, John, for that. You know, when I was younger, my mother, trying to get me more involved, sent me to Catholic church and to Catholic school. And, you know, it was one of those environments where you tended to learn a little bit about yourself, and then you learn to accept criticism. And maybe where it really started for me, that I had an interest in S&M. And it seems like John has the same interest. I seem to be the person who seems to be submissive, however, and he's brought to our attention and to my attention and our program's attention where our opportunities might be. But anyway, with that in mind, I'm kindly going to be joined by Andrew Way to join me for a question and answer session. And in this Q&A session, we have an individual who's worked extensively with John. He is a principal biostatistician for the Chronic Research Group at the Hennepin Healthcare Institute. And he also has been instrumental and tied to many of the research areas associated with the SRTR, and people will have heard him present at national meetings. Andrew is another individual who has been heavily involved in improving the quality of data that is available to us to assist us in making better decisions. And Andrew, can you hear me now?
Yeah, Richard, I can hear you.
Okay, so can I put to you a question, and it's an important one. You know, when I look at John's data, by and large, it seems like my programs sometimes could be viewed as average. When you look at the data and the way that it is presented there, where do you think people should look out of all the potential domains to identify where their greatest opportunities are for finding the data that might help them see where they can make their greatest change to have the greatest impact on greater utilization of organs? Where would that be easily found?
Yeah, I think for programs, that would definitely be the offer acceptance data, specifically stratified by different types of donors, so you can figure out whether or not you're accepting or declining offers at a rate that's commensurate with the nation for example, the low, medium, or high KPI donors.
Yeah, and that's terribly important. Before, when I presented data, just to make it very clear for everyone on the call, when I presented the data that I made relevant from the message of how many donors were present, they were liver transplant donors. I'm a liver transplant physician. If we actually look at 2019, which was a record year for transplantation, I believe it was approximately 12,000 donors that were identified, and the approximate number of total organs transplanted was 33,000. And Howard, thank you for addressing my deficit there. You know, when you look at the data also, and this is another important question to you, Andrew, if you, programs are often concerned about making decisions under risk, and risks are usually associated with particular types of offers like DCD or hepatitis C associated offers and so forth. Within your search tool, are we able to identify what the outcomes are for DCD offers accepted by programs around us and from our OPO, or is there a separate source we need to go to for that?
Yeah, so the risk adjustment models for liver, I'm pretty sure include DCD donor as a risk adjustment factor. So you should be able to see how well the outcomes are nationally for DCD donors relative to brain dead donors. If you want more granular data in terms of outcomes near you specifically, that's something that we are not currently providing in easily accessible format.
Okay. And to everyone on the call, I want to come back to emphasizing that this is a dynamic process. In the bottom left-hand corner of your screen, there is the Ask Me button. You're not asking me, you're going to be asking a person who knows a hell of a lot more about where your opportunities may be in Andrew. But if people would like to propose questions to us about data from a transplant program level, or even potentially from an OPO level and how it might be found to look at your performance, please feel free to click on that box and present the questions to us. Andrew, when I look at our program and the information that was provided there, I'm going to actually move to some slides, which I hope will actually prompt some discussion. So if I can go to the next slide, please. So, prospect relativity is a very important term. And basically, it's how people choose options and what influences their decision under risk. Decision under risk, as people may have heard me talk about before, is a concept that Amos Tversky and Daniel Kahneman came up with, earning Kahneman the Nobel Prize in Economics as a psychologist. And what they worked out is that based on how we look at something, we make a decision, and sometimes that decision is shaped by where we are. With that in mind, if you're a program director or you're an OPO director and you've got a board with the OPO, or you have, in my case, a hospital administrator who oversees our section, and we've had bad outcomes, the next thing is, what do you do about it? If you can find the cause for the outcomes and you've chosen to address that cause and you believe that you have the correct processes in place, would you, if an administrator came to you, slow down transplant volumes so that you can test whether you might have implemented the right action, or if you are certain you have the right action, would you increase your transplant volumes in response to a bad outcome? My question there, I previously have phrased, I've now paraphrased it, so that I want people to consider, if you have bad outcomes, you find a cause and you fix it. If an administrator said, I want you to slow down, would you continue pushing on with high volumes, or would you slow down to examine whether or not you had it right? And we'll talk about that next. Andrew, when you look at your data, a question that programs often actually present is that when they have a decline in outcomes, that they may slow down to address the decline in outcomes. When you look at your data and you had a program, say, of a transplant volume of 100 and they had an SRTR flag report, if they halve their volumes, does that impact how long it takes to clear that flag?
Yeah, I mean, it depends how their outcomes look after that. It's kind of a complex question, because if you reduce your volume, you're also basically the portion that got you flagged is going to play a bigger role in the PSR evaluations until that follow-up is no longer included in the cohort. So it's possible it won't help get rid of the flag, but at the same time, it's a nuanced question.
Okay, so I got a question from Aaron Gilchrist. Has there been any thought given to utilizing our machine learning with the robust data that we have to help analyze predictors of acceptance and to compare them with outcomes?
So we've had internal discussions somewhat about this. In general, we want the risk adjustment models to be relatively interpretable, and many machine learning methods are more of a black box, and it's hard to understand, even more than it already is, where exactly the expected is coming from. In general, we're not super supportive or excited about pursuing machine learning for the purposes of some of the public risk adjustment models for that reason. Perhaps if there was a different question or purpose, for example, some sort of decision tool, we might consider it there, but not for the risk adjustment models per se.
So Andrew, while I move to the next question, I'm going to ask you a brief one, and it's your opinion, so you will not be held to it. Do you think that using AI, we could better push offers towards particular programs so that that organ offers are better utilized? Would AI help us in that domain, do you think?
I think we could already do that, honestly, with the data that we have, because we already observe a lot of variability between program offer acceptance practices. I think the bigger issue there lies in whether or not does the system actually want to pursue something like that? Because it could exacerbate inequalities within the system. And that, I think, is an important question to address for that type of situation.
So a question from Lindsay Smith. The question is, to clarify, if a large list turns down an offer for the whole list, each of these offers is counted separately, is that correct? And so if a high-risk organ is turned down based on another reason, anyone on the list counts as an independent offer turned down. I think basically the question they're asking is, when you look at a list, if a program declines an organ for all of the people, how does that impact you?
Yeah, we include all offers, but there is some complexity here, right? Because we do adjust for where in the match run people are getting offers. So the further down the match run it goes, the smaller the expected you're going to have for declining that offer. And we also only include offers from match runs with an acceptance. So even though your program declined the offer potentially hundreds of times, that offer was deemed acceptable by some other program. So something to keep in mind.
Okay. So another one is a question was presented from Anonymous. Please clarify the difference between wait list mortality and mortality after listing metrics. Yeah,
so waitlist mortality is just the rate of mortality on the waiting list prior to transplant, and the patient mortality after listing metric is the waitlist mortality after listing, including the period before, but also including the period after transplant. So it's trying to capture a more holistic view of the transplant process, including pre-transplant and post-transplant care.
Okay, so it's more of a comprehensive review of your chance of being alive at a year after a transplant if you were listed anywhere.
It's basically, it goes up to 5 years after listing, regardless of whether or not you're transplanted. Some people won't ever get transplanted, but most people will.
Okay. Kevin O'Connor presents a question. Does the SRTR plan to move to reports that show organ allocation categorized by distance rather than just by import or export, now that we've moved to circles rather than OPO sort of based models?
Yeah, that's a good question. I would be interested where in the PSRs Kevin is thinking. That is in a couple places, and it would definitely be pretty interesting to look at. So.
Yeah, it'd be helpful. He points out it may be a better way to understand broader sharing. Clint Hostetler has a question. Interesting data presented by Dr. Snyder, and he thanks you, John, for that. Our OPO uses SRTR data to help us identify hard to place and distressed organs with centers who will use them. Any thoughts on how we can use this data to systematically improve the offer acceptance and distribution process with programs who will actually use organs to patients who would most benefit from them? I think the bottom line is, from the SRTR data perspective, the question would be, is SRTR looking at identifying those programs who are greater utilizers and ways to assist the OPOs in distributing to them and to the patients on their lists?
Yeah, we do provide OPOs on the SRTR Secure site a dashboard type of file that does try to categorize programs that are high acceptors of some of the harder types of organs to place, for example, DCD or high KDPI. So I think those do a relatively good job of identifying the spinners. Of course, a lot of this particular question might require some level of policy change from the level of OPTN, because OPOs still have to either go through the entire match run or initiate expedited placement, which is not well formalized within OPTN policy. So.
Okay, so the next question sort of, it's an important one, it's an interesting one, and it's one that I've tried to do some research on with others, and which is, does surgeon experience play into the numbers? And that would be that the person's imagining that a less experienced surgeon would be more cautious in organ offer acceptance than a more experienced one. We do have data out there that illustrates that acceptances on certain days of the week and on weekends can be influenced. In terms of some programs are less likely at certain times not to take organ offers, or at least accept marginal offers. But does SRTR in any way have the ability to track surgeons, and do you have any ability to track their relative experience in impacting organ offer acceptance?
No is the short answer. There might be data buried in the OPTN system, but it's might be extremely difficult to use. So right now, no is the answer.
So for everyone on the call, we're going to wrap up the questions there, but I just want to bring a couple of things forward. Please remember to use the various opportunities we have to continue the dialogue after this discussion. Thank you very much for those individuals who identified where the Ask Me feature was. And that has actually provided us with some very important points. And to John and to Andrew, thank you very much for your participation in the meeting today. It's been critically important. Sean, I might try to get to your question. I'm just going to quickly wrap up. Actually, I'll quickly do it. Sean puts forward, we just saw an example of an incredibly successful program in Arizona that does DCD, Hep C, high-risk organs. As an OPO leader, we continue to push for more difficult donors and greater than 60 DCDs, etc. With their patient outcomes, as you just reviewed, how do we get other transplant programs in Arizona to basically utilize like they do and achieve their success? I think the answer to that, Sean, is that we will discover that over the next 2 days of this meeting. But that's a terribly important point. How do we all move? Can I go to my next slide, please? So when we have a look at this analysis, my next slide. So if I look at one Midwest program that I was affiliated with, you'll see that's the waitlist additions in the top bar, and you'll see the total number of liver transplants in the bottom bar. To date, in the SRTR report, I know that program's done 36 liver transplants so far this year. There's been a series of changes that obviously have occurred that impact programs in their development. Can I go to the next slide? And with the flagellation that I received from John during this and over the last 3 years, actually slightly longer, my associations with Midwest Transplant Network and also with the programs in Utah, I've discovered that there's a lot of what one can do personally to make changes to make the instrument, which is the machine of all we possess, be successful. In other words, how to set things in alignment and coordinated together with destination thinking in mind. So you'll note there in terms of the this Midwest Transplant Program, the total number of waitlist additions to October have increased from 50 for the year of 2017 to 104, and that the total number of transplants have paralleled that, going from 37 to, so thus far as of October, 63 and soon to be larger. Next slide, please. But it does have me think, and I think it's to Sean Van Wyck's question. and that is, hit the button, please. How do I and every other program to the left of Mayo, Arizona, move to the right as a liver transplant program? And for those doing kidney, I would recommend that you do a similar analysis around your region, around OPOs and your organ resources, which for us is Nevada. And now, admittedly, we've moved to Nevada, but I think that that's not the important part. The most important part is, how do we achieve what I believe is the most optimal program in the country for its outcomes and resource utilization? So with that in mind, let's quickly wrap up. I'd like everyone to enjoy a short break. I hope that people have found this talk interesting. And I'd like to remind people why a great military general and the Alliance are alike. We live in a world of perpetual optimism, and this is a force multiplier. If you can get collectively groups together around one objective, we can all be successful together and transplant a greater number of organs. And on that note, thank you, and I expect and hope to see everyone back promptly, 12:30 Eastern, 11:30 Central, 10:30 Mountain, and 9:30 Pacific. Thank you very much.